As stated in the pamphlet published by the Texas Hospital Association addressing the Texas healthcare crisis in '09, it states that in Texas, a staggering 5.7 million adults and children are uninsured, a problem that impacts the pocketbooks of those who have insurance and the taxpayers forced to carry the burden at the local and state level. As you can see, that back in '09, the uninsured population was the biggest within Texas per capita, whereas since then it's been rapidly growing in size and causing others to pay the price. A primary root cause that was identified was affordable healthcare insurance. So I mean, it was accessible, it's just whether the affordability was there. As of now, it's extremely difficult to pay for basic health insurance, let alone for small businesses or the self-employed even to fathom the idea. In the pamphlet, it also states that more than 70% of all businesses in Texas have fewer than 50 employees, and in 2006, less than a third of those companies offered healthcare benefits to their employees. And why it's such an issue about affordability is that there's two options, either expensive or more expensive. There's no basic, cheaper options in healthcare insurance compared to other industries. So the options are the public options. So whether you participate in COBRA, which is pretty much the government's option for privatized insurance, which is extremely expensive. But then there's Medicare and Medicaid, which cover the expense. But then the taxpayers pay into that, so it's coming from somewhere. Then there's a private health insurance coming from the employers. So in fact, to participate in that, you have to be employed by a large organization who can pay into it. So that's why the self-employed or the small business owners are having such a big issue, is that they can't pay into this just because it's so expensive for them to. If they have like 6 employees, it's cheaper not to get the health insurance benefit just because of the high price. And just comparing it to other industries too, if you take a look at the car insurance or auto insurance or life insurance policies out there, when you sign up for car insurance, you're given options. So do you want the basic plan? Do you want, a little bit extra? Do you want a few, how big is your risk that you want more coverage, that type of thing. Whereas for health insurance, you have no options. With car insurance, life insurance, you're giving a spectrum of things that you can choose from, and a lot more variety and a lot more price adjustment. So it's a lot different than what healthcare insurance is today, and we're really limited, which kind of puts us at a huge disadvantage, and it's not helping our cause. So just a little perspective there for other industries. One thing that I'll bring up is this life cycle, a never-ending cycle of the uninsured. And the uninsured population, like I said before, there's a bunch of options with private and public, but a lot of people opt out of those just because it is expensive. So the uninsured could be working, part of the workforce, or they may not be. So it could be, a wide spectrum of people. So a lot of people think that, since, especially in Texas too, you might get a lot more immigration from Mexico or from other areas surrounding, the Texas borders, but a lot of them are American citizens that are it's just expensive to pay for this insurance from their employer. Looking at the life cycle, it's kind of crucial to understand kind of why things are, the way they are. So to begin at the top, it says uninsured go to emergency rooms for free federally mandated care. So that's Medicare and Medicaid. Hospitals have higher uncompensated care costs just because they're not getting that money. Hospitals increase charges to paying customers to partially offset uncompensated care costs because they're not getting money elsewhere. They need to make sure that they're getting some other place. So they're pretty much just moving the cost around. Insurance companies pay higher claims, passing costs to the insured through higher health insurance premiums. Some employees or employers drop coverage due to high premiums, and there's more uninsured. So it's pretty much just goes in a circle and circle, and more people get more involved, so the volume of the uninsured will increase just because of this. So it's something that needs to change very quickly. I know the Texas Hospital Association doesn't want to wait for the government to come up with a reform just because it is extremely time consuming to get the bill crossed and all that. So a lot of people are doing things on their own, which is good because there is a change that needs to be made. Otherwise, this will continue to become a greater problem, creating more debt, higher prices, more uninsured, and then more unemployed too. So it's not a good cycle that we need to be in, especially during a recession. So that's kind of a little bit more of an introduction about about the whole crisis today. So things I want to talk about firstly is patients versus hospitals. So patients today, many of the federal systems in place, there's unemployment or FMLA that become very generous to those patients that may need the extra cash. So that's good, but because the government is so generous, it pretty much creates debt for ourselves just there. So if they're handing out FMLA or handing out unemployment checks, that money's coming from somewhere. So they have to, I think they need to be a little bit more specific on who they're giving it to and increase the rules and regulations on who should be pretty much getting this money. So I think with that and patients not having that sense of entitlement too might help. So there should be a culture change within our patients today. And a lot of people milk the system, since there are no consequences for not paying for these services, they're going to continue to do it just because they have that sense of entitlement. And why not? They're not, they can get away with it. There are no consequences. So that's part of the reason too. So we need to get that sense of entitlement out the window because of that, that's causing a big issue too. There needs to be like an ethical ground saying, hey, there's no such thing as a free meal. The money's coming from somewhere, and that needs to be educated because right now it doesn't seem like it is. So that's very important too, is just a culture shift within the patients today. And then looking at hospitals, there is a lot of overspending that's been done in creating debt that's not really offset with like the contributions or other revenue that's being seen within our financial statements, which I'll show you examples later on too. It is assumed that some financial debt will occur just because we're never going to turn anyone away. So if a patient's sick, we're going to care for him. If a patient comes in the emergency department and it's life-threatening, we're not going to transfer them, we're going to treat them. So because of that, and if they can't pay, where are we going to get that money? So in order to minimize the debt, governmental aid is in place. So Medicare, Medicaid pays off a percentage off the total fee. But there's also reimbursement incentives as well. So like if we participate in like meaningful use, or if we participate and make sure we get the electronic health record up and running by 2010 or whatnot, we do get a financial reward, which is good. But then again, for all the costs that we accrue day to day that's not being paid, we have to make sure that we're maintaining a positive balance. But while still caring for these patients. So it's an extremely difficult position to be in as a hospital, I'd say, just because you never know, I guess, how much aid or how much contribution you will be getting. So it's kind of a sticky situation. So that's kind of where they are today. There is a lot of just pressure to work with the insurance companies too, so they can pay a lot more. But then again, a lot of insurance companies can't handle the high debt that we see today too. I know just, in a personal, I have a friend who actually I met in another MBA class, but he and his wife just had twins, and they're both premature twins. They're in the hospital for a good few months. They're very, very sick, and they had to file bankruptcy because their healthcare insurance that they've had for years and years and years wouldn't pay for it just because it was so out of scope. So, when you come to that point, it's like, what's the point of having insurance if they can't even help you when you need them to help you? So it's a very broken system. So hopefully, the things that we can do, that the patients can do, so get rid of that sense of entitlement, preventive medicine, which I'll talk about in a little bit, will help us go a long way. So as much as we can do as a nation, each one of us, I think it'll help for, once the reform gets going and Texas hospital associations and associations across the nation get together and come up with some sort of change. Moving forward, as stated, in 2007, Texas hospitals provided more than $5 billion in uncompensated care at cost to patients. So that's a huge amount of money within a year, $5 billion of uncompensated care. The unpaid bills returned for care will continue to be an issue, and hospitals would have to write off or absorb this missing revenue. hospitals need to find a way to make up the missing revenue in other areas. So that means cutting salaries or cutting jobs. I mean, there's a huge shift too in like the nursing structure, which like they're trying to bring in more like APNPs versus physicians, just because APNPs can write orders, they can do everything without having a physician co-sign for them. So they're trying to make it cheaper, but then again, we still need physicians. So will this change if it's made throughout the nation? Will it offset, residents trying to finish medical school because they can't find jobs? Or, it's snowballs in every area, just because this whole healthcare system is so complex. There's no way that if you make one change, it won't affect other areas. So it'll be interesting to see in years to come what the healthcare system will be about. But as I continue, because of this, like I said about the APNP example, many workarounds are put in place to avoid unnecessary duplications, making sure that they're maintaining their bills, that type of thing. Another thing that physicians are seeing too is that they're trying to avoid costs to their patients. So like a room cost could be thousands of dollars depending on what kind of room it is. But patients are now seen in hallways too by some physicians, just because they know that some people are in financial problems or issues that have come up, and by cutting out that room cost saves them so much more money. So they'll see cancer patients in hallways, just trying to give them not necessarily like chemo, but give them advice and what they need to do, maybe to cut the cost that they already have accrued. So things will change as we know it. So overall, throughout like their current healthcare, with hospitals, patients, overall, essentially, you just can't put a price tag on a person's life, and no one will ever do that. So we're going to continue to spend while we care for these patients. So we need to have some catch-all in the background. Like, how are we going to make up this money if maybe overspending was triple the amount this month than it was last month? So I mean, there's got to be a catch-all, and I think with these, with the financial statements I'll talk about too, definitely helps that. So we'll get to that. Moving on to the economic environment, and I kind of wanted to explain like where we are as a country economically, so then you kind of know, it gives us a sense of where we'll need to be in the future, just based off of all these things that are happening. So out of all the countries in the world, the United States is infamous for the large amount of money spent on healthcare, which ranks our number 2 in our GDP expenditures. I do have a table and I'll put up in a second, that our total expenditure on healthcare is at 17.89 in 2010. And will continue to increase if there are no influencing factors to lower this percentage. Another table that I'll bring up, that the average $8,000 on their healthcare costs in 2010. As you can imagine, this cost has increased since then and will continue to increase unless something is done to reform the healthcare system. So as you can see, from 2008, which it looks like it was a higher $7,000, to 2010 it was a lower $8,000. But per person, think about that. So personally, I don't think I cost $8,000 per capita per person, but that, comes into fact of preventative medicine, which I'll talk about in a second. So the main question arises: are you really using that amount of money for your health care? So I personally don't believe I am. For me, I'm a non-smoker, eat healthy, exercise regularly, do my regular check-ins, all preventative medicine, make sure that I'm good to go. So I don't believe I cost that much per year or spend that much on healthcare and expenses and all that. But then again, my goal is to not go to the hospital every time, because I know what that happens. I know that I'll be able to pay for it most likely. As long as it's just like say I just need to get like if I broke my arm or something, okay, I can pay for that on a financial plan if I need to, that type of thing. But a lot of people can't. So it's for me to do my part. I'm more than willing to, just as long as it helps the greater good. But to keep in mind, this was coming from the source Healthcare Accounting. Health outcomes are not necessarily associated with healthcare expenditures, so that's a huge deal. So despite higher spending, Americans are not healthier than their counterparts in other developed countries. So other countries may be spending like way, way, way less, but they get the same outcomes that we are. So why is our cost so high? And I think it comes from a variety of things. So it probably comes from our culture. So that sense of entitlement, that we can go, that free meal mentality. America's also really different because we're a leader in research, which costs money just because you're pretty much just, kind of putting money out the window as you need it. But the outcomes are great from research, and we're very, very proud of what we've done. So research is a big thing, and then technology. So we have the best technology here compared to other countries. So a lot of that goes into play there. But it's important to know that health outcomes are not necessarily associated with our expenditures. So we'll have to do, I think there needs to be a little bit more research done as to why. Where can we cut costs? Why is it so much more expensive? That type of thing. So that's pretty much it. As for preventative medicine I think that should be, I know that in Wisconsin we're cutting education, we're cutting education resources, I guess, by quite a bit. But preventative medicine is a part of education, so that's something that we probably shouldn't be doing as much as we are, just because, even Milwaukee, for instance, there's so many people that have kids when they're 16 or 15, and they can't pay for them. They can't pay for the doctor's bills. They were never taught, how to write a check, that type of thing. They weren't given the correct resources from day one to do what they need to be doing, and by having kids and partaking in this healthcare issues, STDs, any disease in that regard. Like in order to live a healthy lifestyle from the beginning, it decreases your chance of landing in the hospital later, or so to say. So I think education should be bumped up a little bit, especially in preventative medicine, and especially in women or men, and cancer is so prevalent nowadays, and so many other diseases, that it's really important that you have to maintain that preventative piece to save the nation money, but also to make yourself healthy and a good role model for whoever's around you. So that's the culture thing too. So it'll be interesting to see, just even in Milwaukee or, across the nation, how things will change. So that's it for the economic environment. So you've seen where we are, for our expenditures per capita, for how important preventative medicine is. Now we're going to bring this back to accounting more. So there are relation to the financial statements that we review throughout the course. So as you can see from what I've spoke before, is that much cost is absorbed by hospitals. So it's important that hospital accounting is standardized, maintained by rules and regulations, is publicly reported for price transparency, and making sure that we're following, what we need to do. Firstly, it's important to understand the difference between the types of hospitals. So not-for-profit, for-profit, and governmental. We talked about this too earlier in the course, is that, and this is one citation that I'd like to share too, is that today roughly half of hospital health care is provided by not-for-profit organizations, so 50%. Although most providers of healthcare are for-profit groups of medical professionals associated with governmental or not-for-profit healthcare organizations. So as you can see today, so just an example of that is at Froedtert, is we have physicians going back and forth between hospitals. So they may go to the VA and work, or they may go to Froedtert and work. Or they'll have their other sub-grouping of, physician group. So they jump around, because for whatever reason, the for-profit, you get some benefits, and not-for-profit, you get other benefits. So that's probably why it's such a common thing to see. So as for the classification of each category, the for-profit or proprietary class is investor-owned. The not-for-profit is generally community-based, sometimes with a religious affiliation and or private university sponsor. A great example of this is St. Louis University's hospital. So this is affiliated with the Catholic University of St. Louis U, and within the city of St. Louis, because it's right downtown, reaching the members of the city community. So it's a perfect example of what would be a not-for-profit. As for the last category, the governmental public reaches federal, state, county, city, or is sponsored by a public university. All of these areas of hospital accounting, follow the Financial Accounting Standards Board and the Governmental Accounting Standards Board. So both of them come into play. As for financial statements surrounding the healthcare industry, it is common to see the following. So you have a balance sheet, which is number one, or a statement of net assets. The second one is a statement of operations, or statement of revenues, expenses, and changes in net assets. And then the third one is a statement of cash flows, as well as notes to the financial statement. So there's a lot of things that can be added, but those are the required ones. So let's first talk about the balance sheet, and I'll bring up an example. The balance sheet is a presentation of assets and liabilities. So you have pretty much two columns. You have assets and then liabilities and net assets in the other one. It illustrates pretty much just the layout of what the requirements are in each category. So for assets, you have the current assets, assets limited to use, long-term investments, and then you have a total at the bottom. As for liabilities and net assets, you have the current liabilities, the long-term debt, net assets, and then at the bottom, total liabilities and net assets. So it pretty much gives you just a quick information on whether or not you're maintaining your budget equally. So assets and liabilities. As for the statement of operations, so this next one, or also called the statement of revenues, expenses, and changes in net assets, it provides specific information on where the income is coming from and where the expenses are going to and where the absorption occurs. So this statement is one of the most important documents, whereas it's extremely important for reporting. So data analysis and forecasting. So it's important that this is maintained as well. So as within the text, the principal sources of revenue for a healthcare organization, the first one's patient service revenue, so patients' fee for services. Premium revenue derived from capitation fees, so which are fixed fees per person paid periodically regardless of services provided by an HMO. The third one is resident service revenue, such as maintenance or rental fee in an extended care facility. And then the fourth one is other revenues or gains, so this could be charitable contributions, that type of thing. The statement of operations illustrates unrestricted total revenues and gains in comparison to the total expenses and losses. So reviewing the general ledger on uncompensated care, charity care, and provision of bad debts, these come into play within this statement. And they illustrate whether there was an increase or decrease in unrestricted net assets. And as you can see, that the statement also includes a reclassification of bad debt provisions as required by the FASB. So you have the unrestricted revenues, gains, and other support. And then the next category is expenses and losses. Excess of revenue, gains, and other expenses. Net assets released from restrictions, where the reclassification comes in. And then increase in unrestricted net assets. In addition to this, the statement of changes in net assets is also shown, which records the net assets at end of year and the increases and decreases of restrictions. So this statement illustrates all unrestricted net assets, temporarily restricted net assets, and permanently restricted net assets. As a not-for-profit, this is where charity services and contributions are also recorded. So as stated in the text, governmental healthcare entities do not have a statement comparable to the statement of changes in net assets. So that's something that's a little different. And I have found that the governmental healthcare entity portion of it is a little different than other non-for-profit accounting. And the third statement is the statement of cash flows. On this document, which I'll bring up too, the cash flows such as operating or investing. There's also financing here. This document contains the reconciliation of change in net assets to net cash from the operating activities. So this is really important, where the first category you'll see is the cash flows from operating activities. So receipts from unrestricted gifts is here, cash paid to employees and employers. The next category is cash flows from investing activities. So the purchase of property, proceeds from sales, securities, sales of equipment, that type of thing. Cash flows from financing activities, so proceeds from contributions restricted for investment in plan or any future operations, that type of thing. And then you'll see a net increase or decrease in cash and the cash equivalents. So it's important to see like how cash is circulating throughout the company to make sure it's all accounted for. Below that too, we'll have the reconciliation of changes in net assets to net cash, and this is provided by operating activity. So it shows the changes in net assets and any adjustments that would have to be made. So that's important to be done as well. So as you can see, there's 3 activities: operating, investing, and financing. And as I said before, in each of the different categories, you're going to put different things and where the cash flows are. So as required, these financial statements are to be publicly reported in order to maintain transparency within the industry. And just a little bit on transparency within any industry. I'm not sure, probably this is fairly well known, so I'd be surprised if you haven't heard about it. But the Enron scandal a few years ago is a perfect example of not maintaining transparency. Pretty much their ledgers, balance sheets, all their financial statements were frauded or incorrect, and pretty much came to an entire recession and collapse of a forerunner of an industry, and those that are affiliated with the company. So a lot of people lost their jobs. Pretty much the higher administration staff were just stealing from the company, and they lied about it on their financial statement. So it's important to make sure that transparency is 100%. Just because it affects a whole lot of people, and that ethical piece is a huge and crucial quality to have in this industry. So in addition to the financial statements, especially in healthcare, it's important to calculate the net patient service revenue. So in order to do that, pretty much we're looking at okay, yes, we are gaining patient revenue from fees for services. So it's important that we make sure that we are getting that money. As the primary source of revenue, it is very important that we maintain a high percentage of this. So pretty much the formula to do that, to calculate the net patient revenue, we're going to subtract the total contractual allowances and charity care from gross patient revenue. So again, where governmental accounting differs, again, is that the net patient revenue will also have bad debt excluded. So that's another tidbit of change. So what is important, though, when you calculate the net patient service revenue is how things have started to be billed. So on the billing side of healthcare, it's a huge process. So you have what's called coders. So or whoever it is finishes the chart. The coders code from what the information has. If they're missing information, they'll try and get it. Or query the physician, say they need more specificity within the documentation provided. But then there's a lot of human error there, because every coder is, they're probably based, if they have a good coding department, they're based off of, they're maintaining their accuracy when they're doing it. But it's a human being coding a chart. So you have that human error, and then you have that bundling piece. So say someone had a colonoscopy and they used some special instrument. And they found something else because of it. So say they coded that wrong and just bundled it all together, and maybe it should have been 2 separate codes to get, and probably increased the bill or the amount of money that the patient's supposed to pay. That causes the hospital to lose money in the long run. So there's a lot of human error and then things that go along with that. So that's the first piece, is the coding. Then the bill is reviewed and dropped and sent to the patient. So whether or not that's going to be paid, that's another thing. So hopefully the patient pays and then gets sent back to the hospital, and we're good to go. But overall, I think generally with the human error piece of it, it's extremely crucial that ethics comes into play, and that it's as accurate as possible. Just so you know exactly what the current trend is and the current data, and it's accurate data, and then you can forecast accordingly. So in conclusion, the Texas healthcare crisis is honestly just the tip of the iceberg in regards to the root causes arising with affordable healthcare insurance. Accurate financial statements and analysis of the revenue and things along those lines. So ultimately, the services that hospitals are providing are not being reimbursed and are losing revenue to providing care to patients. The reason this has become such a huge issue is because the increase of costs that the hospitals have been forced to provide. Just because of the uninsured population, the amount of uncompensated care that's being written off each day by hospitals, and then the lack of reimbursement that the government or insurance companies are providing. So there's a lot of pressure within this culture transition as well, because everyone kind of has to play a part. But overall, I think as long as we have the key players set. Everyone has that common goal, that shared vision. Government reform is in place. I think it will take some time to get through and see the light of the tunnel, but hopefully it'll get there soon enough.